Everybody, thank you for joining our Tuesday morning CAS conference. It's a real pleasure for me today to have a very good friend and someone I consider a mentor, William Wijns. And William wanted to do something different for this CAS conference. We wanted to talk about FFR and IFR, since William is really one of the pioneers in the field. But instead of doing a regular talk, what William offered to do was he asked for questions from you. So we sent out emails and we collected questions both via emails and via Twitter. And thank you, Rachna, for helping with that. And so we got so many questions, though, that we realized it's not possible to cover them all in one talk. And so we're going to do this in two successive talks. The second talk, which we'll try and arrange and let you know about, will be a more sort of case-based talk, because there were a lot of questions about FFR usage in left main, bifurcations, ACS, aortic stenosis, and tandem lesions, for example. We thought we'd do that in a second meeting, and thank you, William, for agreeing to that. And today we'll concentrate on more the theoretical parts and the clinical data and so on. So William, without further ado, thank you so much for taking the time on your vacation to spend an hour with us. We really appreciate it.
I'm delighted to be with you and your team. And I want to congratulate you, Azim, on this initiative that is very successful and very much needed. So these are my conflicts, my relations of interest, which is maybe a nicer word. Not really anything that I think impacts on what I'm going to say. As you may know, I've moved to Galway, which is a device hub. By the way, is my voice okay, or should I speak louder?
It's perfect, William.
Okay, thank you. So as you said, Azim, and thank you for agreeing to address it in two parts. This will be more like conventional, but based on your questions. And no surprise, but the main questions are when, how, and why. And then if time permits, I'll say a few words of where I think I'm going. If I would give you upfront the fil rouge of the presentation, or the message that I'd like to get across, is that I really think that physiology is becoming of utmost importance for the next generation in the post-ischemia and era. So we'll try to address these three questions: when, how, and why today, say a few words about the future. And for the second session, if we can find a slot, these are some of the specific patient or lesion-related issues in using physiology that you came up with, and would like to address those in a very practical way in the next session using tracings and cases. And so there is room for maybe more, although this is already quite a lot to cover in 1 hour. So let's get started with the when, okay? And I let you think a bit by yourself in your mind, or maybe you write it down, what you think are the situations where FFR, IFR, or any other physiological index will be of limited or unproven value. And while you're thinking, I'd like to bring you back to history that I was fortunate to be part of. And in fact, the pressure gradient measurement was there from the very beginning, the very first case with Andreas Grünzig. And this is actually a tracing from, I think, the first patient that we got from, I think, through Bernie Meyer. And you see the two pressures, proximal aortic, good quality, and then the smaller one, because it was a damped signal obtained through the DG Schneider catheter. And proximal to the stenosis, the mean values were about the same. As soon as you cross, you could see that the distal pressure comes down. It goes further down during the balloon occlusion. And then when you release the balloon, while the catheter is still across the lesion, you could see that the average value of the distal pressure had actually increased from before the dilatation. And that's the very moment when the surgeon in Zurich at the time left the cath lab and said, this thing is going to work. Actually, Andreas Grünzig was supported by the surgeon. He wasn't supported by his fellow radiologist, nor was he by the cardiologist at the time. Of course, the fluoroscopy was not very good. The film you would not get immediately. And the fact that the surgeon had decided this is going to work just from seeing the gradient being released gave a lot of courage to Andreas to continue. But of course, we very quickly noticed as obvious that the fact that the catheter was big and that you would measure the gradient through the catheter actually made these measurements artifactual. It was exaggerating or contributing to the stenosis, and this remains. Now, what has happened historically is that the pressure gradient disappeared. The focus was on developing the catheters, making them more easy to travel through the coronaries. And there were not too many lumens at the time, so the lumen for the pressure measurement was given up. And it's interesting to see that 30 or 40 years later, things are coming back. So this is a list of situations coming back to your question, when not to use it or when to use it. So in STEMI, very majority of cases you won't use it. Same in non-STEMI, because you will know what is the offending, the culprit lesion. The question of bypass has been raised, and we'll talk about it in detail, the data that are available. One big limitation, of course, is that these indices mostly look at the epicardial vessel, and so there are limitations related to microcirculatory disturbances. Heart failure is an issue. We can talk about it in detail next time. Growing impact or question is, how can we use it in patients with aortic stenosis? CTO intervention, of course, you won't use it on the vessel that's occluded. And there is also the situation of, if the stenosis is severe, you don't need the physiology. And I'd like to spend a few moments on tackling that issue. And let's ask ourselves, what's a severe stenosis? Well, it's one that you measure by QCA, if you don't rely just on eyeballing. And if you measure FFR in stenoses of increasing severity, you will see that a conventionally significant stenosis, 50 to 70% by QCA, there's quite a number of those that have preserved FFR. And even if you go higher up, 71 to 90% in the middle, still you do see a number of lesions where there is no significant gradient. And only when you almost go to a functional occlusion, 90, 91% or more, then the rate of normal FFR is very low. So these are the figures. And this is shocking, but you wouldn't realize unless you start measuring those severe stenosis. But by and large, there is quite a number of angiographically severe stenosis that are not functionally positive by physiology. So where is the problem in the low adoption? The problem is us, it's the physician. We don't think we need it. And this is a study that Gabor did, Gabor Toth. We submitted, we sent to more than 500 interventionalists a set of images, and we asked them, when would we use imaging? When would you use FFR? And when do you feel that you can make the right decision for that patient based on the angiogram only? Okay, so in 71% of those cases, physicians felt, I know what to do. I don't need this physiology thing. And we knew, of course, what was the physiology underlying those 71 obvious stenosis, not where it would not be measured. And you can see that in a number of them, actually half of them, physicians felt it needs to be treated and FFR was preserved. And that represents 1/3 of the collective of all cases. So the issue is that it's perception of need. We feel that we don't need it. And in doing so, we are missing a number of opportunities, and we're also performing what I have to call inappropriate procedures. So this is a graph. These are all cases from ALST considered for PCI, where we measured by QCA, either the diameter stenosis on the vertical axis on the left side, or the MLD absolute dimension on the right heart. Let's come on the right side. Let's focus on the left side here. So we have vertical axis percent diameter stenosis from, threshold at 50%, and we have the FFR that we measured in all those cases. And then you have 1 and 3 highlighted. Okay, that's obvious. It's appropriate. Okay, it's a tight stenosis under 3. It's a mild stenosis under 3, and the FFR is normal, as you would expect. And 1 is also okay. That quadrant is fine too, because you see a significant stenosis by angiography and the FFR is abnormal. But there are so many other dots in the 2 other quadrants. Quadrant 2, 1/3, okay, nearly 1/3. There is a significant stenosis by angiography, but FFR is preserved for a number of reasons. Stenting dose makes no sense, we know that. And the other way around here, quadrant 4 is even worse because we claim it's mild on the angiogram, but the FFR was depressed and sometimes very severely. By the way, this is often the LAD. So the bottom line is that angiographic guidance for stenting results in inappropriate PCI in about 50% of the cases. And this is true across the range of angiographic stenosis severity. Meaning that if you don't incorporate it in your daily practice, and not just when you think you need it, we're not doing the right thing for the patients. And of course, that shows in those trials comparing PCI with medical therapy. So that's the when. And I'm trying to convince you that for our future, for the future of our field of coronary intervention, it's going to be important to measure it more and more often, like we have been doing in places like Eindhoven, Aalst, or Dr. Park, for instance, in Korea. Now, how can we measure it? And this is a bit technical, going over the different indices. I will cover quickly hyperemic versus resting. I will insist on how important the co-registration with angiography is and why this explains the superiority of what we measure in the lab versus all the non-invasive tests. I'm sorry to make such a bold statement. And there were some questions on your behalf regarding discordances and borderline values and thresholds, etc. So let's spend a few minutes on this and bear with me. Couple definitions, as many acronyms, but I think these 3 ones are important. The ratio of distal over proximal pressure over the entire cardiac cycle is called PDP, PD over PA, okay? Distal pressure divided by proximal pressure. FFR is exactly PDPA, but measured during maximal hyperemia. So any gradient measured outside maximal hyperemia cannot be called FFR, and IFR was invented, described by Justin Davis from Imperial, and it's the PDPA during a very specific moment of the diastole. We'll come back to it later, but it's measured at rest, and this has opened the field again to resting indices. Okay, the principle of FFR, well known to you. We unmask transcoronary pressure drop by increasing flow during maximal hyperemia. And the denominator is what it should be in the absence of stenosis, and that's what's shown on the upper graph left. When you have an epicardial stenosis, you may not measure a gradient at rest, but you can unmask it by increasing flow, by reducing the resistance in the central pool there, intramyocardial, and that sort of unmasks and give you the pressure gradient and tells you about the stenosis severity. It's a very practical, it's meant to be very practical. You can argue about sophisticated physiology, etc., but by and large, PD over PA at hyperemia works in most conditions. And that is because there is a linear relationship between flow and pressure, as shown on the right, during hyperemia, and that's absolutely not the case at rest because of a compensatory mechanism. This is just one example. The angiogram is there. It's an ostial LAD, not very severe on this projection. Of course, you would want to see more, rightly so. This is during intravenous adenosine. The red is the proximal ostial pressure, mean value in red as well, and the distal is shown there. As you see here, the center of the wire is distal in the LAD. From the beginning, we did pull the pullback curves. We did that from the beginning in Austin Eindhoven, and this is one such pullback. And what it is teaching us, in addition to the fact that the stenosis is significant, is where it's located. Although we didn't have at the moment precise co-registration with the angiogram, you can see that the location of the obstacle to flow is very limited. It's sharp, it's focused, and it is at this ostial LAD site. So the message here is that it's not just about the stenosis. It's about the obstacles to maximal flow over the entire region, over the entire vessel. And we're basically talking about circumflex, LAD, and RCA regions. So let's get out of the concept it's just a stenosis. No, this provides us information about the entire epicardial segment that needs to be corrected in such a way that it does not represent an obstacle to maximal flow. Now, the resting gradient, as I mentioned, was criticized by the physiologists initially, but for reasons that they're working on normal vessel and the focal stenosis. The reality in our patients is quite different. And in fact, Justin Davis and the team noticed that there is quite a number of gradients at rest as well. What he did is capitalize on this wave-free period, which is a specific period during diastole, where he felt the resistance would be very low, so that the IFR value would be almost equivalent to FFR. This was proven wrong. You know, IFR is great, but the principle, the hypothesis that it was based on is not right, because in fact, if you give adenosine and you measure during the wave-free period, you can see that the gradient is very different. So this created this somewhat excessive controversy between, you know, one club against the other that is now resolved because the IFR came up with outcome data, so discussion closed. But it is true to say that it doesn't represent hyperemic flow, but at least the resistance is constant during that period. So another option, and you've observed it while you're in the lab, when you inject contrast, the pressure gradient changes, okay? And that's because contrast is no blood, creates some ischemia, and there is a reactive hyperemia. So it is obvious that you could perhaps use that as a hyperemic agent instead of adenosine. And so this was studied by Niels Johnson and the team, and this is one protocol example for one patient. So on the left, you have PDPA. I don't call it FFR because we have measurements that are obtained outside maximal hyperemia. You have the pressure on the right. So the upper thing is the PDPA, the ratio, or the FFR when hyperemia is maximal. And the other one is aortic versus coronary. And look, upper left, after contrast injection, you see that the PDPA comes down. So there is some degree of hyperemia that is not quite as severe, as deep as when you give intracoronary adenosine, that's IC adeno, or intravenous adenosine. But you can use contrast as a mild hyperemic agent. And if you get your result positive, well, you know that the stenosis is significant. So after the validation of IFR, and this is here how it compares to each other. So contrast is slightly better in terms of area under the curve compared to FFR than IFR, or by the way, the entire PDPA, whether it's systole or diastolic or only diastolic. So what we have seen with the emergence of IFR is that you have many options. And this has been great because it has increased the adoption of physiology. We have underestimated initially how difficult it would be for colleagues to use adenosine. We got it almost for free from the pharmacy of the hospital, but we've underestimated. And we've also underestimated the complexities, calibration, etc. So having a resting measurement helps a lot. So from left to right, you have the choice now between so many options. Left side is maximal hyperemia, the conventional traditional FFR. I just mentioned about the contrast FFR, which is submaximal hyperemia. And then you have the family of non-hyperemic pressure ratios, resting ratios that either measure the gradient during the whole cycle or during a part of diastole. And of course, Ifr is there, reigns supreme there. All these other indices, the new ones, and there is additional ones, have compared themselves to Ifr and or to FFR. The only two indices that have robust data in terms of patient outcomes are FFR and Ifr, period. Now, if you show that with another index, RFR, for instance, you have the same measurements as with Ifr, you could argue that, probably the outcome would be the same, but it wasn't tested. These are some of the details, how these different indices differ. Sometimes very little. It's a matter of, developing something that is specific, that perhaps has some intellectual property. And so you can use any of those, but be aware that the only ones that have outcome validation are FFR and Ifr. And here it is, you know it, you've seen it. This is the 1-year outcome. They've produced the 2-year outcome. And basically, whether you use Ifr or FFR with the proper threshold to decide whether a lesion should be treated or a vessel should be treated, strategies are non-inferior to each other. They're slightly different if you want to look at details, or maybe not details. Of course, our Ifr is faster, no contrast, no adenosine. Also, the number of patients that are required abnormal is slightly less with Ifr than with FFR, but it's statistically significant. And you're not surprised, because we are not looking at the maximum hyperemic potential of the stenosis, we're looking at the resting value. So you would anticipate that slightly fewer lesions would be declared abnormal. Now, you were interested in discrepancies. There are discrepancies between Ifr and FFR. In general, they're around 10% of the cases. You can think of two situations. Ifr is abnormal, okay, and FFR is preserved. That's the most difficult one to understand. And then you have a situation that you can anticipate it. FFR is abnormal, Ifr is preserved. Now, that case is shown on the right hand here. You have a small gradient at rest, but a large gradient at hyperemia. That is usually due when you have lots of pressure loss due to separation coefficient there, okay? And this shows it here, Ifr 0.94 preserved versus FFR extremely low. Of course, this is an extreme example. If you go to the left part, okay, there you see that there is Ifr abnormal, 0.89, but FFR during hyperemia is preserved. What happens? This is microcirculatory dysfunction. For some reason, flow did not increase. Okay, and therefore your FFR remains normal. Or there is a big myocardial infarction downstream. There is little viable myocardium. Flow only increases to those areas. And the stenosis, even though present, does not restrict the flow to that segment. So these are the discrepancies. I don't think they're that interesting, to be honest, because it's not so much, as we will discuss, about normal, abnormal. It's a continuum of ischemia. Now, a good thing, a very good thing that Ifr did is bring back the concept of co-registration with the angiogram, and in an easy way. First of all, the software application was brilliant, and you know it. You can just move your wire, and there you have the information. You don't need to be sure you have stable hyperemia. So this really tells you about the entire vessel. And that's where I started off with. We want by PCI to restore the conductance of the epicardial segment to the entire region. And of course, stenosis is important, but the entire vessel matters. So the fact that you have here with this pullback, an idea where the pressure loss is, and the yellow curve there shows that it's a focal spot. Okay, great case for PCI. You don't need to go and do a lot of intervention on the other segments of that LAD. That, of course, has contributed tremendously to adoption of IFR, the fact that you have this co-registration with the angiogram, which is our GPS. Yeah, without the angiogram, we wouldn't perform PCI. Okay, that was a bit long, perhaps, but I hope I went through the key learnings regarding the different indices with the pro and cons, and the fact that we're happy to have actually all of them on board, because what matters is to do more physiology. The third question, we said when or when not, then we said how, now why? Now that is the big thing for your future career. Are we going to do only the acute MIs and the severe non-STEMIs? Are we going to leave stable elective cases to drug therapy? Of course, my view is very different. I'm so sad that a trial like ischemia did not incorporate measurements of physiology in more cases, and not just moderate or moderate lesions, actually in all of them. It's interesting that from design, the study has the functional information because all patients underwent a CT, so there would be a possibility to actually compute FFR from that CT in all those cases. And I bet you that the results of the trial would be completely different if you would analyze it based on the CT FFR information. But anyhow, even without this, which is wishful thinking, today we can state a number of things. And this has been confirmed over and over again. We're doing it to relieve ischemia, and PCI is extremely good at that, better than anything else. And all the consequences of ischemia, quality of life, the use of drugs, of course, angina, etc., etc. Now we have data that need to be confirmed, but I think they're already very strong, that PCI, when guided by anatomy and physiology, actually prevents heart events, not mortality, but myocardial infarction. And I'll show you that data because I really think that this is the cornerstone of your work for the future. And I'll say a few words about, it's a dirty word, accountable care. I'll explain to you what's coming. We have been focusing on the indication so far, but we have forgotten to measure the success of the procedure. So why would we measure physiology? I'm not going to say anything about relief of ischemia and its consequences. I'm going to focus on the event prevention. Okay, we have long-term data of 3 major FFR trials, and we've learned from each of them. We've learned that it is safe to and treat medically and not to stent when there is no gradient. Actually, that's the strongest evidence we have. No gradient, stent doesn't help, actually it makes it worse. We have 5 years of FAME1, and if you compare angio versus FFR guided stenting, results are better. They're clinically better, they're also better by use of resources and cost effectiveness. And FAME2, we've shown on the triple endpoint, I grant you that FFR guidance is better for patients than drugs with respect to the composite endpoint. Now, there was some idea from the medical group, analysis of the medical group of FAME2, because their FFR was measured, that if the FFR was severely abnormal, you would have more target lesion failure. And this is not just revascularization, there were also some MIs there. So what it shows here is that the risk of having an event under medical treatment increases when your FFR of the lesion that was not treated because you were assigned medical therapy, that risk increases. And sure enough, this led to this concept that you have seen, conceptual framework, that if you compare the relative merit of medical in blue versus revascularized treatment, on the left side, you see that the lower the fractional flow reserve, the larger this gradient, the greater the benefit. And on the other side, and this is where, of course, we're not doing good things to the patient when we perform inappropriate procedures. Actually, if we PCI a lesion that has a preserved FFR, we can only make it worse to start with the risk of a periprocedural MI. Now, this is a nice concept. Is it real? Well, Niels Johnson, who works with Lance Gould, you know, the father of coronary physiology, has looked at this concept and shown it to be valuable based on a very sophisticated analysis of lots of data on the left side at a study level, on the right side at the patient level. Look at the patient level on the right side. We talk about many events, including death and non-fatal MIs, okay? Of course, revascularizations as well. But the model is right. The lower your FFR, the higher the gradient, the potential benefit between revascularization and medical treatment. Please note that the threshold, the point where the two curves are crossing, is higher than our clinical threshold for the presence of ischemia, which suggests that perhaps the mechanism by which those hard events are prevented is not directly related to the relief of ischemia in those cases, but that's an hypothesis. What to remember is that it's a continuum of risk, okay? So it's not traffic light story, it's a continuum of risk. So the numerical value of FFR shows this continuous relationship with prognosis, lower FFR, higher risk, larger benefit from revasc. And sure enough, this is the evidence that there is prevention of wild-type MI with PCI. From a pooled analysis by Dr. Zimmerman and colleagues of 3 randomized trials, you know, 2 New Englands and 1 Lancet, it's not bad. In cases with unstable angina or even MI, we're talking about the non-culprit, okay? And you had to look for long enough time. You needed the numbers, larger numbers. Each of these trials in isolation wouldn't show it. But if you pull them and you look for long enough, here it is, okay? So gradually, but progressively and surely, the curves diverge. You need to wait at least 4 years to start seeing something significant. But this therapy, when it is FFR guided, prevents acute MIs, okay? And it's an absolute reduction that is very significant. If this was a pharma trial, everybody would rush around and say, revolution, revolution. Because it is PCI, nobody talks about it. You may not even have seen this paper. If not, I really encourage you to read it. And it's very well done by Zimmerman. We have nearly a 28%, we have a 28% reduction of the hazard ratio in developing an acute MI if you're undergoing FFR guided PCI, okay? There is no impact on cardiac death in this population. One important point to remember, yes, there is an impact, but it is potentially jeopardized by periprocedural MI. Okay, this is a landmark analysis, very positive interaction term. If you look beyond 7 days, very significant effect. If you look for the entire population, we have periprocedural MI. So it is important to try and do whatever we can to reduce periprocedural MIs, because once you have periprocedural MI, you're out of the study, okay? You have your event. And these events are to be taken off, potential benefit over long term in terms of MI prevention. Now, much more shocking, and I want your attention for this one. Look at the left side. What is this? Are we doing with time, Azim? Are we okay? Yeah. So look at the left side. I say this is shocking. You have a distribution of FFR values measured at the end of the procedure. When you say, beautiful, great images, fantastic result. Measure FFR. And what's shocking is that in quite a significant number of patients, we haven't restored the conductance of the epicardial circulation. We're sending those patients home with a quote unquote successful procedure that didn't have much of an effect. And if you look at the outcomes, of course, by terciles, you can see it on the right, the worse the final result after PCI in terms of FFR, the more the risk of repeat intervention, or MACE, mostly repeat intervention, but also non-fatal MIs and death. So in this era of accountable care, when our work is scrutinized, if not criticized heavily as it is, we must not give to our opponents any reasons to attack us. First of all, we need to measure the FFR or the IFR to be sure that the stenosis that we're about to treat is worth it. And second, we have to come at the end of the procedure with the confirmation that, yes, we've done the right job. Even the surgeons measure the flow through the graft at the end of their operation. We don't. We rely on the images. Since then, many, many studies have looked at this, all observational. I counted something like 60. 3 of them used IFR. It needs to be confirmed, but please, please consider measuring more often, nearly all lesions. And second, measure at the end of your case. This is just another study, one of many, that shows that if you have a poor FFR result at the end of your procedure, sure enough, your patient is going to have increased rates of TVR over, not just at 1 year, but over the long term. What is the aim? How good enough? What should we reach? What should we aim at in terms of post-PCI FFR? Well, in theory, a normal, totally normal epicardial vessel is no obstacle to flow whatsoever, even during the worst hyperemic condition. We've looked at this in normal, truly normal arteries. It's an old study. We took patients coming in, young patients coming in for PFO or other procedures, and we measured FFR in their vessels under maximal hyperemia, and you see that in all these truly normal vessels, it had to be above 94, okay? Some even 1, like the theory would predict. Of course, when you're dealing with patients that have coronary disease and mild plaque everywhere, you do see that atherosclerotic arteries, some still have very good FFRs, but there's a number there in the green zone. So it means that, again, it's not just about the stenosis, it's about the entire vessel. So if you're measuring your post-PCI result, it has to be absolutely correlated with the angiogram. There has to be co-registration so that you can see how much is the pressure loss and where it's located. If it's in your stent, we'll improve it, can improve it. But if it's somewhere else, maybe there is another stent needed, or maybe there is more aggressive secondary prevention. So the higher the better, but something that's above 90 or 0.88 for FFR is okay, and I'm sure we will have soon similar threshold values for the IFR. So this is what I wanted to say in a few words about accountable care, and I can't insist enough on how important I think this is for the young generation, for the next generation. I'm done, I'm nearly done. But we lived through a period where we were not truly accountable, and these times are over. So physiology in combination with anatomy co-registered is going to help us identifying the proper indications for our procedures, and we need to work on a metric for procedural success. Few words, if time permits, yes, on the future of interventional physiology, and it's in one word, image-based computation. And I'm going to make a blunt statement here. If we rely on our own perception, whether we need it or not, I mean physiology, we've seen what we're ending up with, okay? We're not measuring it often enough or at all, and we're not using it to validate our results. So we're going to get us out of the equation, and we'll make it available all the time. We won't have to decide whether we need the functional information. We're going to have it because we can calculate all these indexes, we can compute them from the images, and that is the future. And of course, FFR-CT has shown the way. And it's going to increase even more because that's the next change ahead of us. diagnostic coronary angiography will disappear within the next 5 years. It will be replaced by CT. It will increase the number of patients that are presented to you for intervention. But with few exceptions, the diagnostic interventional invasive angiogram will be replaced by the CT. And of course, that CT anatomic information will have to be complemented by the functional information, whether it's the heart flow solution or some other solution. Time will tell. So today, the options for physiological assessment, they really span over the entire spectrum of coronary disease. We will have it non-invasively through CT. We have it, of course, in the cath lab, and we've discussed the value of the hyperemic pressure ratio, the near hyperemic with contrast, and all the non-hyperemic wire-derived pressure ratios. But the new field is in red. It's the imaging based. And we can do it from angiography, we can do it from OCT, and we've just shown that we can do it also from IVUS. So, couple examples. On the left, the FFR CT, 3D reconstruction from a conventional angiogram gives you the inherently co-registered FFR, okay, with a color coding of where the pressure loss is taking place. And I'll show you a couple examples on how this can be done from OCT without pressure wire, without adenosine, or from IVUS. First of all, how robust is it when you compute, call it QFR, there's many solutions, many different solutions, CatWorks, others. How does it work compared to the real thing, to FFR measured with the pressure wire? Here it is. Incredibly, incredibly accurate. And more important than sensitivity specificity, in a way, of course, it flows from it, but is the likelihood ratio. For any diagnostic test, it has to be as high as possible, but as close as possible to 10. And the negative likelihood ratio has to be as low as possible, but around 0.12. This is as good as it could be. Carlos Colette did a meta-analysis of all our data, including QFR, CatWorks, and other, which was available at the time. And don't be surprised here by the spread. It's actually extremely good. The correlation is remarkable between pressure-derived FFR. And also the variability on the right from the blend Altman is very good. There is a little more variability in the lower values, but these are abnormal values anyhow, okay? It's the spread in the abnormality, but if you go to above 0.8, it's very, very good. So that explains the good positive and negative likelihood ratio, meaning that without even you asking or thinking of it, you will have the QFR information available to you for all vessels from any diagnostic angiograms. Why consider doing it in combination with OCT? Well, that's for the intervention. You know, the QFR will be very useful for the diagnostic angiogram, but for the interventional procedures, you know, you will have at the same time the plaque, the stent, and the physiology. But right now, you need two separate instrumentations. This will be achievable from one go. You instrument and do your OCT, and the system will compute the OFR for you. In this case, it's abnormal 0.75. And again, the 3D or pseudo 3D reconstruction there shows you where the pressure drop is taking place. This is not something for sophisticated core labs. This example here is entitled to show you how much time it takes. This is after stenting, minimal correction. This is live, right? It takes less than 1 minute and you end up with those images. Okay, you can move your cursor along where you want. You have the stent and you can identify whether the pressure loss, if there is any, is located inside or outside the stent. Okay, just one example, and then I will conclude, and hopefully there is little time for questions if you have any. So this is one example. Okay, that's the easy case. You finish your procedure, you did the OCT, and you have quite significant malapposition. Significant malapposition causes significant pressure drop inside the stent. You wonder, I see malapposition, should I tag it or not? If there is pressure drop, definitely yes. In this case, it is 0.6. You know exactly where it is. And you'll also know that the rest of the vessel is okay. Okay, so we have a stent OFR here of 0.94, and we have a vessel OFR of 0.82. This is one of those patients that you would have sent home with a beautiful angiographic result, okay, but a poor functional result. And it's easy to fix because you fix the stent, the malapposition, and here it is. And you can, of course, repeat your OCT, calculate within a minute the OFR, it's called OFR in this case, and this time the vessel went up to 0.86 and your stent went up to 98. So diffuse disease, the patient certainly needs aggressive secondary prevention, but at least our procedure, we can document that it has been functionally effective. So I'll stop here, and I'm happy to entertain questions if you have time.
Hi, William. Thank you so much. That was really fantastic. I'm going to ask one of my fellows to do some of the questions that have come through and moderate, because we really try and make sure that this is geared to the fellows, the session. So I don't know, Manaf, if you can unmute yourself. In the meantime, I wanted to ask about just the last part about the OCT FFR. I mean, because that's been a challenge, particularly here where I work in the US. There's a lot of issues around costs and reimbursement and so on. And I also think, like you, that physiology is important for us to understand which lesions to treat, but it can also help you in getting a good result from that. So doing FFR after you've treated the lesion is important. But that's where also I think intracoronary imaging is also very important, because it helps you understand what it is you're treating or what you need to do to make physiology better. And so the thought of having to use both modalities in a case increases the costs, obviously, and makes it at times impractical. So I'm looking forward to seeing OCT FFR in our practice, because I think it will facilitate that. Manaf, did you have? Yeah.
Let me just say one word, Azim. It's of course essential, and the question is, we're not going to do this in all patients, and what you do first.
Right.
Ideally, the wish would be that your final angiogram transformed into QFR would tell you whether or not to do imaging, okay? Mm-hmm. If your final QFR is abnormal, you image. Unfortunately, the QFR will miss the malapposition case that I've showed you.
Okay.
But still, you could think of a strategy where you do you compute post-PCI QFR in all your cases, and if it's abnormal, you go and have a look. Okay. Now, if it is a complex procedure, lots of stents, long stent, left main, etc., you may as well do the OCT anyhow, and you will take the functional information from the OFR on board at the same time. So there's many scenarios that we need to work on.
Before I pass it to Manaf, I mean, when you think about, there are 3 or 4 systems now for angio-based FFR. I remember when they first came out a couple of years ago and we tried using them in Milano, I was a little bit skeptical because of the amount of work that was required, as in the post-processing. You really had to re-look at the QCA it was measuring, maybe do some corrections yourself. And to me, that seemed almost impractical in real life. I would want something that was very automated. Do you think we're getting there now?
Yes, absolutely. So the number of systems is, it's more than 10 now, I think. And what the more recent ones and also the new iterations of the initial ones are working on is exactly that. You needed someone initially really trained to do it right, to get the good results. And of course, if it's going to be a given, if we need to rely on a technician or a fellow that really has been trained, you know, go to Leiden for a week, etc., etc. That's not going to work. So I have worked only with QFR. I have no experience with the other systems, but you're absolutely right. This needs to become something that is, you know, just like I've shown you the OFR, because OFR, it's the case. It is very, very low operator interaction.
So I'm going to put on Manaf. Manaf is one of our interventional fellows with him, and he's going to, you know, do the rest of the questions with you. Manaf, hopefully this talk inspired you about how important physiology is going to be for your future. So I'll give it over to you.
Absolutely. Thank you, Dr. Wijns. That was a great talk. We were all totally engaged here with your presentation style as well. So thank you again. One of my questions is we have in our patients, we see frequently microvascular dysfunction that we assess sort of off the cuff by looking at flow and kind of the clinical picture and looking at just the way contrast clears in the artery. We don't have specific ways to assess microvascular dysfunction here. But my question is, you know, and we do quite a bit of FFR. How do you tease out, you know, possibly a false negative FFR, like you mentioned earlier, which can be a result of microvascular dysfunction or poor outflow and resulting in suboptimal hyperemia? How do you tease that out when you're doing your hyperemic index, and how do you incorporate microvascular dysfunction into your daily practice with FFR?
Thank you. I'll mute myself. Yeah. How should I say? It's of course a huge topic. You see, with PCR, I go around the world. I see lots of people and different practices. The importance of microvascular or the frequency, how often you see patients where angina and symptoms are related to microvascular really differs from region to region. And for instance, there is many areas in the world where you basically, you know, you're overflown with stenosis, severe disease, etc. And there is very little focus on microvascular. In the Western world, where people have lots of procedures and we see it much more. So to me, it's a sign that, you know, we're more advanced in the disease and sicker patients, just in general. So now it deserves a lot of attention. I think we're coming to the point where you can really identify where is the obstacle, okay? And I cannot in, you know, a few seconds go over all the steps and the different tests that need to be done, but I think we're coming to a situation where there is strategies on how you explore those patients. But in any case, you will have to make sure in the first place that the epicardial function is there. So the difficult situation is where the FFR is abnormal, and in combination you have microvascular dysfunction, because you will stent the patient, you will do the right thing, but the person will continue to complain, and so then you need to look at what's going on microcirculatory. Then you have patients that have chronic microcircular dysfunction and absolute normal epicardial conductance. It has to be verified though, because in many cases, people say you had a stent, he keeps complaining, it's microcirculatory. Well, you know, you have to make sure the stent is okay and also the rest of the epicardial segment is okay. So it is becoming an integrated evaluation, more complex than just the, you know, simple FFR, IFR that we've been talking about. But the tools are getting there, and perhaps also the drugs. So I don't think I'm answering your question entirely, because it would take me more time, but we can discuss this maybe also during the next session. Basically, how do you do, what are the different steps of a comprehensive evaluation of the circulation, not just one that is restricted to the epicardial segment.
Yeah, I think, you know, the confusion often becomes, because I think assessing the microcirculation, William, can be challenging. We had a really nice talk from Javier about how to do it, and it was great. And that was in patients who have normal epicardial vessels, right? And I think that alone is challenging. When you start now trying to combine the microvasculature with patients who have abnormalities in their epicardial vessels, it becomes even more complex. And that's why I think many of us are challenged. I'm just going to respond quickly to Mohammed Ali, who asked a whole lot of questions. Mohammed, these questions are great, but we're going to leave those questions until the next session, because they're exactly the questions that we'll be addressing in our second session with Dr. Wijns, about CTOs and aortic stenosis patients. So our apologies, we just don't have time today to address that, but we'll address it in our next session. Manaf, go ahead. I think there were some interesting questions in the Q&A too.
Sure. So Dr. Monrad mentions here that FFR values during an IV infusion usually drop to a stable value, but there are sometimes instantaneous or brief drops, maybe during inspiration or some other time period where the value can briefly drop to a lower value and then come back up. The question is, during the validation studies, is the lowest value that is reached or seen by the transducer, should that be the value used, or is it a stable value that is reached after a stable infusion of the IV? Should we be looking at that?
Yeah, absolutely. It's one of the issues with adenosine is the stability of the signal. Particularly when patients have this chest pain, this breathlessness, they start, breathing a lot, and it can impact, as you said, the signal. One way to minimize it, but it's an obstacle to using it, is central infusion. Yeah, because some of the variation is due to the metabolism of adenosine while it circulates in the peripheral blood. And central infusion gives you stable values. I would say that in most cases, first of all, you're not taking one beat, right? The systems, you can set it up, but usually you're taking a mean value of 5 beats. So that's one thing. The other thing, if you're going for yes or no, abnormal, normal, very seldomly, I would say, do you have a value that goes from 0.81 to 0.79 because of that. So I wouldn't worry too much. The main problem to me is the pullback. I tried to convince you that interrogating the entire vessel is absolutely critical, that you have to do it in co-registration with the angiogram. When your hyperemia is not stable, that is a difficulty, and that's where I think the resting IFR pullback has an edge, has an advantage. So I don't have an answer except for the fact that if you're doing intravenous adenosine, it's better to do it via a central vein or one that has a very good flow. And the averaging of the measurements, I think, is what you can do. There are other means to induce hyperemia. Regadenoson has been one that has been heavily promoted by Nicopedals with just intravenous injection. It's used for imaging, non-invasive imaging. I've never used it myself, but it's assumed to be more stable.
We have recently had a slew of focal vein graft occlusions in symptomatic patients with CABG. I know in the beginning you said there's limited data. Do you ever use FFR in vein grafts, and are there any caveats?
Okay, so this is the entire interaction between FFR, IFR, and CABG has different aspects. First of all, should the lesion be grafted or not on the basis of the FFR, IFR? Can we use it to assess functional outcome of the procedure? And your question is about the graft is diseased, not occluded, it's diseased. Does FFR help? In my experience, never. even though there are severe lesions, there is thrombus, there is everything. You see the size of those residual lumens is usually so tight that, so large, sorry, I was thinking of the next sentence. The size, the residual minimal lumen of a diseased vein graft is usually still pretty large, above 1.6 millimeters. So you don't get a gradient across those. And also, if it's tighter, you know, you have so many collaterals, so many sources of blood that are measured by your wire pressure and not seen by the angiogram. To me, I've never found it useful to decide about intervention on a graft, if that is the question, specific question you had.
Right.
I've not used IFR though, but I suspect it's going to be the same. Not useful.
Okay.
Is that your experience?
Yeah, I was too. I don't ever remember using it in a graft, not to assess the graft. I've used it in grafts to assess downstream disease, and I've put it, gone down the graft into the native vessel. But my experience has been very similar, and also because we know that the rate of progression of disease in grafts is so rapid and unpredictable that I'm probably going to treat it irrespective of the IFR, because the next time I see it, the graft's going to be closed if I don't.
And that's a great comment also about, how do you react to an FFR or IFR value? It is one piece of information. It is not the, traffic light thing, yes or no, you may not, what have you done again? Yeah, no, I mean, you have to integrate it with all the rest.
Yeah, I agree with him. I think that's been, one of the more challenging parts of the whole FFR IFR story, is that I think all of us have seen how, we've all been at presentations before in the past where almost the message was it's black and white. It's a traffic light, you get that value, you treat. And I just love how all the recent presentations I've seen in the last couple of years have moved away from that and talk about this gradient of risk, and that, a patient with a 0.83 FFR may need to be treated depending on the clinical scenario. And it doesn't mean that it's just black and white, which, it forces us to be what we are as clinicians and take the patient and put the patient at the center of our decision making.
That particular patient with the LAD 0.83 typical angina on the lesion. Remember, FFR, all the measurements are done under nitro. Okay, so we've eliminated basically spasm. That person may well have a mildly stenotic lesion when the vessels are fully dilated, but could well be responsible for his symptoms with superimposed spasm. Treated.
Manaf, I think we just passed 8:30. Any final burning questions? Dr. Wijns is on vacation, so I don't want to keep him too long.
No, I think we're all good here. Thank you so much, Dr. Wijns, for a great talk.
Thank you all, and all of you have submitted questions and ideas or challenges, and we'll try to do, this was, I realize, a bit like a lecture and very theoretical maybe, but next time we'll try to really go into the practical aspects of using it in specific patient or lesion subsets.
That'll be great, William. Thank you so much. We'll work with you to find a date. I think everybody will look forward to the next part. But I personally, speaking for myself and the fellows, enjoyed today because it wasn't the typical lecture. It was really addressing specific points and questions many of us have around FFR and physiology. So thank you so much. Enjoy the rest of your vacation, and I'll see you soon. Okay. Bye-bye.
Thank you all.
Thanks, Manaf. And thank you, everybody, for joining.